Welcome to Clinical Minute. Jennifer is a divorced 43-year-old white woman, gravida 1, para 1. She is a new patient presenting for her annual well woman visit. She is healthy, with no significant medical issues. She has been in a monogamous relationship for 6 months. She has an LNG IUD for contraception and also uses condoms for STI prevention. She thinks her last Pap test was 3 years ago. She tells you it was negative. You do not have access to her health records. She reports light but regular menses, and her LMP started 2 weeks ago. Do you recommend cervical cancer screening at this time? You remember that the screening algorithms were updated in 2013 to incorporate the latest evidence relating to HPV testing for various populations and clinical scenarios. The new algorithm reflects the fact that co-testing with Pap and HPV tests increases the detection of disease and also identifies women with future risk. The negative predictive value of the HPV test also allows for widening the screening interval in women who are at average risk. You check the ACCME guidelines and see that co-testing with Pap and HPV tests is recommended for women ages 30 to 65. You also recall that in April 2014, the FDA approved standalone HPV testing for women ages 25 to 65 years. You remember reading that HPV test results help stratify for the risk of progression to cancer. HPV testing also allows for less frequent screening due to the test's high sensitivity. The rationale is that a normal Pap and a negative HPV test provide high assurance that cervical cancer is not present and is not likely to occur in the next few years. When both tests are negative, the 5-year risk of CIN3 is 0.16%. The 5-year risk of cancer is 0.016%. HPV testing also identifies women who need increased surveillance. A positive HPV and a normal Pap test reflect increased risk for either missed disease or the subsequent development of CIN2 or 3 and cancer. You know that both conventional Pap tests and liquid-based cytology are acceptable screening methods. Well-controlled clinical trials have found little difference in performance of the two methods for identifying high-grade disease. Laboratories prefer liquid-based cytology. Liquid-based cytology also facilitates reflex HPV testing, co-testing, and testing for gonorrhea and chlamydia. The American Society for Colposcopy and Cervical Pathology, or ASCCP, stated in a 2013 report, "Over time, growing evidence and the improved understanding of the natural history of cervical cancer have led to a growing recognition that early recommendations for annual screening were excessive and led to an increased rate of harms. Women at any age should not be screened annually by any screening method. Rather, recommended screening intervals for women are based on age and clinical history." The report further stated, "Annual screening leads to a very small increment of cancers prevented, at the cost of a very large excess of unnecessary procedures and treatment due to the high prevalence of transient, benign HPV infections and associated lesions, most of which will regress within a year or two, or, of those that do not, are many years on average from causing cancer." You check the ASCCP guidelines and see that co-testing with Pap and HPV tests is recommended for women ages 30 to 65. You also recall that in April 2014, the FDA approved standalone HPV testing for women ages 25 to 65 years. Additionally, you remember the recommendations for screening special populations. HPV testing is not recommended for younger women because of the high prevalence of HPV infection, the length of time required for persistent infection to cause precancerous changes, and the desire to minimize unnecessary invasive testing in young women, most of whom will not develop cancer. You recall that routine cervical cancer screening should be offered to all women, regardless of sexual orientation. Transgender men with a cervix should follow the same screening guidelines as females. You remember reading the American College of Obstetricians and Gynecologists Practice Bulletin, which explained that certain factors increase the risk of CIN. Women with HIV infection, immunosuppression, exposure to diethylstilbestrol, DES, in utero, or previous treatment for CIN2, CIN3, or cancer may require more frequent cancer screening. You provide Jennifer with written educational materials about the HPV and PAP tests. You explain that the PAP test looks for precancerous changes, while the HPV test detects infection with the virus that can lead to precancer if it persists. You tell her that it is recommended that women her age receive both tests. You also recommend testing for chlamydia since she has a new sexual partner. She agrees, and you administer the tests. While she is still in the office, she asks, "Is the HPV infection related to the vaccine my daughter's pediatrician recently mentioned?" You explain that the HPV vaccine is recommended for boys and girls ages 11 to 12 to prevent infection from the most common strains of HPV. The HPV vaccine is most effective when it is administered before the onset of sexual activity, before exposure to the human papillomavirus. If children receive the vaccination before age 15, the new CDC recommendation states that they only need 2 shots. You receive Jennifer's results 1 week later. The cytology is negative, and the HPV test is positive. What is the recommended management at this point? You know that the ACCME screening chart offers 2 options for women with a negative cytology and a positive HPV test. The first option is to co-test in 12 months. The second option is to order reflex genotyping of HPV 16 and 18. If it is positive, provide a colposcopy. If it is negative, co-test in 12 months. Under option 2, genotyping, either reflex or immediate, there is an option to triage women aged 30 or older with the PAP negative, HPV positive result. If the genotype is positive for HPV strain 16 or 18, follow with immediate colposcopy. If the genotype is negative for these 2 highly oncogenic strains, use repeat co-testing with PAP and HPV tests in 12 months. You call Jennifer with her test results. She sounds upset and says, "So my boyfriend cheated on me? I really thought I could trust him." What do you tell her? You know that the HPV virus is primarily transmitted through sexual intercourse. It is transmitted via direct genital contact rather than via body fluids like most STIs. The virus can also be transmitted by oral genital contact and anal intercourse. Because the virus is transmitted via skin-to-skin contact, condoms do not completely prevent infection. You also know that most HPV infections are cleared by the immune system in 4 to 20 months. 90% become undetectable after 2 years. The remaining 10% of infections that persist have a high probability of progressing to precancer and cancer. The HPV type affects both the likelihood of persistence and the risk of progression to precancer. HPV type 16 persists longer than other types and also is especially carcinogenic, with a risk of CIN3 of 40% at 5 years. You tell Jennifer, "Virtually all people who are sexually active have the infection at some point in their lives. Infection does not mean your partner was unfaithful. There is no way of knowing how long you or he has had the infection. Most women who have HPV do not develop abnormal cells or cancer. Women who have HPV in their cells a long time are at greater risk for developing abnormal cells or cancer." You explain that you will order a special test that will determine the next steps. You order reflex genotyping for HPV 16 and 18. A week later, the results return. They are negative. What do you recommend now? You call Jennifer and, thinking ahead, you know that the recommended management of results obtained 12 months after a positive HPV test with negative cytology is: if the repeat HPV test is negative and the cervical cytology is normal, the woman has a very low risk of having significant cervical disease and can safely wait to be rescreened in 3 years. The majority of women with initially positive HPV tests fall into this category. If the repeat HPV test is positive or the cytology shows ASCUS or greater, regardless of the HPV test result, colposcopy is recommended, even if the Pap test remains negative. If repeat HPV testing is still positive for high-risk HPV DNA at the 12-month follow-up and the Pap test shows LCIL or greater, regardless of the HPV test result, colposcopy is recommended. You also remember that there is a separate algorithm for screening and managing women ages 21 to 24. The annual incidence of cervical cancer in U.S. women in this age group is 1.4 per 100,000. Almost 55,000 cytology tests are run for every cervical cancer diagnosis in this age group. The data justify the need for screening, but suggest a strategy of observation for minor abnormalities. The management of women aged 21 to 24 should be as conservative and minimally invasive as possible. Women 21 to 24 also have a separate algorithm for abnormal results. There is similar management for similar risk strategies. For ASCUS and LCIL, women no longer go directly to colposcopy. Instead, order a Pap test follow-up in 12 months, even if there is reflex to HPV and it is positive. This strategy gives time for clearance of HPV infection and regression of cellular abnormalities. Before you hang up the phone, you remind Jennifer to schedule her appointment for 1 year from now and that she'll receive a reminder postcard. You document details in her health record.